Today we are going to look at a very interesting disease, not very common nowadays, but still hyperuricemia is common. Gout per se you may not see, but gout management is very important. Straight away I am going into the pathway of metabolism of uric acid. You know, proteins are broken down into amino acids. These amino acids have got purines. They also have got pyrimidine bases. Pyrimidine bases are, there are two types of bases in the amino acids, purine bases and pyrimidine bases. Pyrimidine bases do not form uric acid. They are metabolized in a different path. The purine nucleotides or purine bases are converted into a product called hypoxanthine. This hypoxanthine has to be converted into xanthine by an enzyme called xanthine oxidase, also called XO. Xanthine oxidase is the enzyme which converts hypoxanthine to xanthine. And xanthine has to become uric acid. And this uric acid, how is it metabolized? 2/3 of that is excreted in the urine. 1/3 is through the alimentary tract. Suppose 100 milligrams of uric acid is formed, 2/3 goes through the urine and 1/3 goes through the alimentary excretion. And also, uric acid has got a tendency to get deposited in certain tissues. A part of it, small quantity, gets deposited in the tissues. And this deposition will occur in case of hyperuricemia. The tissue deposition will occur in excess of the clearance. How the tissues clear that little uric acid? They have macrophages. These macrophages will eat it. Oh, very tasty, they will take it. And then the macrophages will digest it. But the macrophage function is limited. If more number of uric acid molecules are available, the macrophages, once the phagocytize, they become inflamed. The activated macrophages settle in a particular place, particularly in the selected joints, and start producing inflammation. So where can I attack this particular problem? I can increase the activity of xanthine oxidase by giving drugs which increase the activity of xanthine, like oxypurinol, allopurinol, febuxostat. The newer drug febuxostat also acts there on increasing the efficiency of xanthine oxidase. I can use drugs which make the urine clear uric acid faster. These are called the uric drugs. I can use them. Or I can reduce the dietary intake of uric acid by restricting certain foods. Or I can control the inflammation by giving colchicine or NSAIDs or even steroids. This chart is both a pathogenesis and treatment. So how do you treat hyperuricemia or gout? Put this chart and say this is how I treat. So a clinician should always look at the pathology in line with the treatment always. That's what we are trying to do here. So allopurinol and oxypurinol are those which inhibit the xanthine to uric acid. That is, they reduce the production by suppressing the xanthine oxidase. Xanthine oxidase facilitates xanthine to uric acid. If I suppress the xanthine oxidase, uric acid synthesis is reduced. Or the one that is formed, I try to throw away out in the kidney through the urine by increasing the uric drug. Or I can use at the site of inflammation as the anti-inflammatory, particularly colchicine, and then the NSAIDs. So this is the mechanism I use. The newer drug febuxostat also is a xanthine oxidase inhibitor. Understood now? Now, one line above you have not told. 33%, that is 1/3 of the uric acid is from the diet. 2/3 is endogenously synthesized from purines. We have amino acid metabolism going on. From the amino acid metabolism, 2/3 is synthesized endogenously and 1/3 is exogenous or dietary. So even if you restrict the diet, the uric acid formation will be going on for 2/3 of the extent. Now, an overview of gout. Gout, again, just like the other diseases which we have looked at, gout is a systemic illness and it is a metabolic disease. Okay? It is a systemic illness related to metabolism of particular purine, which results in inflammation in the end, defined as a peripheral arthritis resulting from the deposition of sodium urate crystals, SUC, in one or more of the joints. Okay? Now, the sodium urate is available as monosodium urate, MSU crystals. MSU is monosodium urate. Deposition of uric acid in the softer tissues as monosodium urate. Deficient purine metabolism, serum uric acid elevation will be there. Demonstration of the intra-articular monosodium urate or MSU crystals is the diagnosis. How do I confirm the diagnosis? Not by looking at the uric acid in the blood, which may be elevated without gout. The only way I confirm gout is take the joint fluid, joint aspirate, take the joint aspirate, and then look for MSU crystals. The prevalence is around 1% in the population. That means 100 people are there, 1% will be having hyperuricemia and gout. So, gout is 5 times more common in males compared to premenopausal women. Prevalence increases with age and increasing serum uric acid concentration. There is a strong familial history. So, if you ask the patient, sir, I am having this problem, my father also used to have it. He will say, because a familial predisposition is there. Okay. Now, what is the spectrum of gout? Clinical spectrum of gout. What are the various ways it can present? Acute inflammatory monoarthritis, hyperuricemia without any arthritis, just 7 milligrams or more, tophaceous urate crystal deposit like crystal gout, and interstitial renal urate deposition with interstitial nephritis, or the stone formation within the urinary tract itself, urolithiasis. Interstitial is not in the tubes, it is in the parenchyma of the kidney. Here, urolithiasis and nephropathy can occur. Okay, so acute inflammatory monoarthritis, hyperuricemia alone, tophaceous and crystal gout, interstitial nephritis, with deposition of the urate in the interstitium, urolithiasis, uric acid stones themselves can form and cause nephropathy. These are the 5 ways it presents. So primary gout, there are 2 types of gout, just like primary hypertension and secondary hypertension. Primary diabetes and secondary diabetes. Primary means cause unknown. Secondary means there is a genetic defect or some problem. So 10% is called overproduction gout. 90% is called under excretion gout. Primary gout is 2 types, either due to overproduction or due to under excretion. Overproduction happens whenever there is nucleic acid turnover. When is the nucleic acid turnover? Suppose there is cancer. There is a multiplication of the cell, and each cancer cell has, while multiplying, produces lots of amino acid catabolites. These catabolites are purines. Usually, per excess nucleoprotein turnover, as happens in lymphomas, leukemias, and various epithelial malignancies. Increase in cell proliferation or death. Sometimes what happens, the cell proliferation is increased and cell turnover is increased, as in case of psoriasis. A rare genetic disorder called the HGPRT deficiency. What is HGPRT? Hypoxanthine guanine phosphoribonucleotide transferase deficiency. Hypoxanthine to guanine. Hypoxanthine guanine phosphoribonucleotide transferase deficiency. This syndrome is called the Lesch-Nyhan syndrome. You may be questioned in a short format answers. This is one of the questions usually. So, Lesch-Nyhan syndrome, a rare genetic disease. And drugs can produce secondarily. Suppose I am using thiazide diuretics, they are gout producing, loop diuretics, pyrogenamide, particularly the treatment of tuberculosis, hyperuricemia. Recently, 2 months back, I had a lady around 45 years, put her on tuberculosis treatment for cervical tuberculosis. She ended up with 11 milligrams of uric acid and had pain and joint pains. What do you do in that situation? Uric drugs generally are not required. Just stop the pyrazinamide, it will go. Just give support some NSAIDs. Wait for that first 2 months only. After 2 months of treatment, pyrazinamide is anyway dropped. Now your uric acid is 4.4. Come to normal without doing anything. Just gave NSAID support. We know it is pyrazinamide related. So whenever you are giving pyrazinamide, you should be careful. Hyperuricemia and gout can occur. Likewise, cyclos, ethanol abuse. Ethanol, alcohol and uric acid metabolism are interlinked. In fact, the disease is found more in men who are alcoholics in the history. That is how it has come. So it is more related to the ethanol abuse and fluid deprivation. Dehydration also makes the uric acid to precipitate in the tissues and produce gout. Okay. So now, what is the substance of this slide? Primary gout, secondary gout. Primary cause unknown, secondary there may be several causes. Primary gout, 10% overproduction. And second one is underexpression, 90%. Secondary gout, mostly lymphomas, leukemias, other malignancies with high cell turnover, or psoriasis, or Leschinahan-like disease, or thiazide and loop diuretics and pyrazinamide and cyclosporine, ethanol abuse and dehydration. Now, what are the signs and symptoms? There are two phases of the disease. One is called the acute, the other is called the chronic gout. Acute phase looks like any other septic arthritis, but it is particularly in a particular place, a small joint of the metatarsal joint, metatarsophalangeal joint, first metatarsal phalangeal joint. Within a few hours, the morning is all right, goes to office, by 1 o'clock, excruciating pain. Probably this is the worst pain that anybody can express. So the worst pain that can be experienced is uric acid podagra pain. Podagra is the swelling of that ball of the great toe with involvement of the first metatarsophalangeal joint or MTP joint. Swelling, redness and tenderness. Rarely it may affect knee joint, wrist joint, elbow joint, sacroiliac and hip. Very commonly the lower limb, particularly the MTP joint of the first MTP joint or foot joints. This is acute. Very sudden onset, develops in a few hours, redness, swelling and tenderness of the MTP joint, podagra, most excruciating pain, probably the worst pain one can think of. Sometimes larger joints may be affected. Chronic gout, destructive tophaceous gout, much greater chance if untreated, rarely presents as chronic illness. Now, how much time it will take for the patient to progress? First of all, he will have asymptomatic hyperuricemia. Over a period of years, he will develop acute gouty monoarthritis. Then he will go to interval or intercritical gout. Interval gout means there is no acute attack, only hyperuricemia is there. Again, he will get into chronic gout. Acute asymptomatic hyperuricemia, acute gouty monoarthritis, interval or intercritical gout, and then chronic tophaceous gout. This is the sequence. What is tophaceous gout? Tophi means the swellings, hard swellings that occur at different points. I'll show you the picture also. Incidence has decreased over the last few decades. Why? We have very good drugs now. Uricosuric drugs are there, xanthine oxidase inhibitors are there, early recognition is there. Routinely you do uric acid as a test, you pick up hyperuricemia and keep treating those fellows. Very rarely it is. Now we see it. 25 to 50% of untreated patients after 15-20 years. Where does the tophi occur? On the olecranon, on venic bursas, on the digits they can have, on the helix of the ear. This is called the helix. It's called the tragus. It's called the helix of the ear. And then they damage the bones, periarticular structures, and soft tissues. Palpable measure of total body urate load. If you see gout, that means there is a high amount of urate load in the body. Other extra-articular complications can also occur. Uric acid caliculi. What are the extra-articular manifestations of hyperuricemia or gout? One, uric acid caliculi, 10 to 15%. chronic urate nephropathy, those with tau5, acute uric acid nephropathy, and then this is particularly people who are undergoing chemotherapy. Because during chemotherapy, a lot of cell turnover will be there. The cancer cells are killed because of chemotherapy, and a lot of purines are released into the body, and there will be deposition in the tissue. Hypertensive renal disease is most common in gout. Hypertension and gout are associated. In fact, uric acid today is a cardiovascular disease marker. Persons with uric acid, high uric acid, even if they do not have gout, they are prone for more cardiovascular manifestation. That is why cardiovascular is a cardiovascular marker. So you do a uric acid routine. Now, how do I diagnose? History is very typical, and physical examination confirms it. Orthocentesis, that is, aspirate the fluid from the joint under anesthesia, very painful joint. You put the needle, he will just jump and die. So you have to anesthetize by regional block. You have to give a regional block to that whole part of the limb and then tap the fluid. And you have to look and you see how the negative birefringence. Refringence is the reflection. Negative birefringence. Negatively birefringent, free-floating uric acid crystals. These are MSU crystals, monosodium urate crystals. Uric acid level is raised, but it may be normal in 30% of people in spite of gout. That means uric acid will not exclude gout. Uric acid may point that the person may have gout, but it will not exclude the presence of gout. Now, more important test is not serum uric acid, and collect a 24-hour urine and measure the uric acid. Okay, more than 800 milligrams means overproducer. So treatment will be xanthine oxidase inhibitor. Less than 800, under excretor. That means urine not showing urine. Give uricose-uric drug. Less than 600, no drug treatment, urine-free diet. These are international guidelines, American College of Rheumatology guidelines. But whatever I am speaking to you is not from the hat or not from what is practiced in a village in India. These are all standardized international guidelines only. These presentations are. So whatever you do, you are following science. So how do I diagnose? Clinical examination, very striking. The onset of pain, the gout, the tophi, the location, and are very typical. Confirmed by orthosynthesis. Birefringence, negative birefringence is the clue. And then uric acid levels may be measured, but may not be elevated. Then how do I understand? Your 24-hour urine collection you take and then measure uric acid, serum urine uric acid in that. If the urine uric acid is less than 600, no worries, only give purine-free diet. What is purine-free diet? I will show you. Less than 800, but more than 600, give uricose-uric drug. Uricose-uric drugs means that those which promote the excretion of uric acid in the kidney. Okay. More than 800, those which prevent the conversion of hypoxanthine to xanthine and xanthine to uric acid. That step is blocked. That is the XO inhibitors, xanthine oxidase inhibitors. That is for more than 800. Okay. This birefringence test should be done under a polarized light microscope. It is not just under an ordinary microscope. There is what is called a polarized light microscope. And in that only it will be visible. You see some clinical pictures. You can see the digits are affected here. In the upper picture, you see the X-ray. There is a lot of erosion of the first and second phalangeal, interphalangeal joint, that is the proximal interphalangeal joint. You see the podograph, the ball of the great toe is red and swollen and tenderness is there. There is deposition, as you can see below, within the joint space of the metacarpophalangeal joint, and then the olecranon showing the tophi. These look like pustules. When you touch, they are hard. You can rub and feel very rough and hard, not like a pus, but they look like small pustules. Okay? These are on the olecranon. Okay. Now, These are the ACR criteria, American College of Rheumatology criteria for diagnosis. Patient must have any 6 of the 11. What are the 11? More than one attack of acute arthritis. Maximum inflammation within 1 day is happening. Erythema over the joint. Podagra, that is the typical site, or history of podagra. Unilateral tarsal involvement, not bilateral. Tophus, that is a tophi. Hyperuricemia more than 7. Asymmetric swelling on the X-ray. Subcortical cyst without erosion. Negative culture for infective arthritis. So these out of these, any 6 will make you diagnose the disease. Acute ACR criteria, more than one attack of acute arthritis, maximum inflammation occurring within few hours to 1 day, erythema over the joint, podagra, that is a typical first MCP joint of the foot, MTP joint, metatarsophalangeal, first MTP joint, history of podagra, unilateral tarsal involvement, hyperuricemia more than 7 milligrams, asymmetric swelling on the X-ray, subcortical cyst formation without erosion, negative cultures for infective endocarditis. Infective arthritis. Okay. How do I treat now? Because my diagnosis is over, my background pathology and biochemistry I understood, and then the presentation I understood, the types I understood, presentations we understood, the flow of disease, acute, hyperuricemia, asymptomatic, acute attack, in between, no, and again chronic tophaceous gout, that is the flow. How do I treat acute attack? Yeah. Acute attack, you should not try to use drugs like, xanthine oxidase inhibitors, and they take a long time. The fellow is dying in pain. You have to treat the pain. So NSAIDs are the best drugs. Or colchicine, where they act, both of them act at the site of inflammation. So either you use colchicine, 0.5 milligrams oral every 2 hours. Every 2 hours may require up to 6 milligrams. Colchicine is given half milligram tablet every 2 hours up to 6 milligrams, that is 12 doses in a day. Neutrophil microtubular assembly inhibitor. How does colchicine work? There is a neutrophil microtubular assembly inhibitor, so much so the neutrophils are not brought to the site of inflammation. It acts as an anti-inflammatory drug. Stop with response. When the response is there, you can stop colchicine. Or when diarrhea and vomiting side effects occur, you can reduce or stop colchicine. Can be used for chronic disease, risk of bone marrow suppression is there. This drug is the drug of choice for acute attack, and it is not for chronic tophaceous gout, but it may be continued in chronic tophaceous. Joint aspiration followed by intra-articular administration of steroids, IAS. Acute attack, joint aspiration with IAS. Or oral prednisolone, 1 milligram per kilogram body weight, up to 1 to 2 weeks, and then tap. Or give ACTH, 40 to 80 units IM or IV, or Solumedrol. Opiates, Tylenol is paracetamol, Tylenol for analgesia. So what do I have? I have NSAIDs, which can be used, and then in acute inflammatory response, and then colchicine, 0.5 milligrams every 2 hours, joint aspiration with followed by intra-articular steroid injection. Prednisolone, 30 to 60 milligrams for about 1 to 2 weeks. ACTH, 40 to 80 milligrams, or Solumedrol, opiates and Tylenol. This is the treatment for acute attack. Okay. Now, suppose NSAID, when are the NSAIDs contraindicated? When the patient is having grade 3 or grade 4 or grade 5 chronic kidney disease, peptic ulcer disease, congestive heart failure, NSAID endo. Any one of these are contraindicated. Then NSAIDs are not contraindicated, then they become the first choice. First choice will be NSAIDs. Look for the contraindications before prescribing NSAIDs. Is there a history of PUD? Is there renal insufficiency? Is he having CHF? or is there NSAID intolerance? Yes, he has got any one of those things. Are corticosteroids contraindicated now? This is the question. And then they are not contraindicated. Corticosteroids are the drug of choice. If by any chance corticosteroids are contraindicated, then the corticosteroids are given. Number of joints involved you see. If there is only one joint, you don't give systemic steroid, give intra-articular steroid. More than one joint is involved, oral or systemic. That's the flow chart. Corticosteroids are contraindicated, yes, colchicine. This is the flow chart. Not straight away putting colchicine. First assess whether is NSAID compatible or not. NSAID can be given. That's the best choice. If NSAIDs are not tolerated for any of those reasons, then think of corticosteroids. No contraindications for steroids. What are the contraindications for steroids? Pregnancy, uncontrolled diabetes, immunosuppressive state, already having chronic renal disease, chronic hepatic illness, and then already is edematous, so many kind of osteoporosis. These are various contraindications for corticosteroids. And consider how many joints? Only one joint. Okay, I put a needle and give it there. Other body is spare. More than one joint is affected. Give oral or systemic corticosteroid. Supposing corticosteroids cannot be given, NSAIDs cannot be given, then you are left with the other anti-inflammatory specific agent, the colchicine. Okay, so that is the flow chart. That completes. Treatment algorithm for acute gout, there is a reference there from where it is taken. Everything has got a reference. Now, what are high purine diets? Yes, you should know. Patient will ask, sir, many people say some foods I should not take. You tell me what? No, you don't take purines. What does he know? Now, purines are the ones responsible. Better you avoid all purines, just like saying avoid coffee. If you say that, how does he know what? Then you will ask, what are purines? I don't know what is purine. And all meats, including organ meats, and not only muscle, liver, and other organ meats also. Muscle meat, organ meats, meat extracts and gravies and seafoods. In fact, almost you can say every non-veg except chicken. Chicken is the only thing which doesn't have much of the purine. Whereas meats and liver, other things they have. Yeast and yeast extracts. If he is taking some yeast extracts or yeast or any B complex group of drugs, keep them away because they promote the purine metabolism. Beer and ethanol containing beverage. Beans, peas, lentils, oatmeal. That means vegetarian proteins also. How long? Until the acute attack passes. Not permanent. Permanently, if you make him devoid of protein, he will come with some other disease. Okay? Kwashiorkor, he will come. Or marasmus. Okay? So, certain vegetarian food also is having spinach, asparagus, cauliflower, mushrooms are rich in protein. Green leafy vegetables, lentils should not. What other vegetables you can take? Pumpkin, this and all those which are coming up above the ground, which are not very leafy, not lentils, he can take. And milk doesn't contain much of purine. He can take dairy products. Eggs also he can take. Eggs do not contain dairy products. Egg, milk, curd, dairy products are permitted. Vegetables, okay. Green vegetables, you better avoid. And then particularly the leaf. This you should have. Patient will ask, sir, you said purine food. He will go and search in the internet. What are purine foods? If you don't ask him, then he will get a list of 108 foods. Almost nothing can be taken. Okay, this is the important message you have to tell him. So now, prophylaxis of chronic gout. Can I prevent it becoming chronic? Can I give a prophylactic treatment? Yes. Diet low in purine, particularly seafoods and meat. Then you start giving him vegetables, lentils and all. They generally become a vegetarian, you advise. Decrease the uric acid by 1 milligram, they will decrease this diet. Weight loss is essential. Limit consumption of alcohol, modification of medication, and then avoid salicylates, diuretics, and niacin. Niacin is the one which promotes the purine metabolism. Uric acid lowering therapy, also called ULT. This should not be the choice in acute gout. Because uric acid lowering therapy, if you start, 4 weeks it will take. In the meantime, the fellow is having pain. So you should not think of giving a uric acid lowering therapy. No. So my teacher told we can give xanthine oxide and febuxostat. For acute attack, what's febuxostat? What are you talking? There's no point in giving uric acid lowering therapy. Two approaches, if serum uric acid is more than 7 milligrams. One, uricosuric therapy. They allow the uric acid to go out from the body. 24 uric acid excretion is less than 800, then you give sulfenperazone and probenecid combination. 500 milligrams of probenecid, 100 milligrams of sulfenperazone. Urine output is 200 ml must be maintained. You have allowed the uric acid to go, but there is no water to go. So you have to have enough water also. Then only the uric acid will come down. So more water intake should be there to maintain at least 2000 ml of urine. Means you must drink 3000 ml of fluid. So normally our urine output is around 1500 ml. So 2000 means more than normal. Xanthine oxidase inhibitors for underproduction gout to decrease the uric acid production only in the long term. Useful in overproducers of more than 800, then you can. Two drugs, allopurinol and febuxostat, are available. They are not useful for acute attack. Precipitation of acute attack can occur when you use these drugs. Chronic gout. Uricosuric for under excretors, probenecid or Benemid, available as Benemid, probenecid and sulfenperazone and Turane. And then avoid patients with renal disease. Consider NSAIDs to avoid exacerbations in chronic gout. So the prophylaxis, initially 250 milligrams twice orally for a week, and then maintain the uricosuric drug 500 milligrams oral twice daily. If symptoms persist, give for 24-hour urate excretion. You see, incrementally increase it by 500 milligrams every 4 weeks. Maximum treatment is 2000 milligrams. Of what? This is all about the story of the previous one, sulfenperazone. Okay. Now, there is one more wonderful drug called the benchbromarone. Benchbromarone is a new addition to the armamentarium treatment of uric acid. Gout retains uricosuric effects at a dose of 25 milligrams to 150 milligrams and have a creatinine clearance of at least 25. That means not grade 4 and grade 3, grade 4 and grade 5 CKD, but anybody 1, 2, 3 CKD also they can take. Good uricosuric effect is there, effective in mild to moderate, may cause hepatotoxicity. It's not available in all the centers. Benchbromarone. Now, treatment of chronic disease. Allopurinol is the treatment of, here there is no colchicine, no NSAID, because we are treating chronically we are treating the gout. So we have to use now allopurinol, tophaceous deposits, uric acid consistently more than 9, or persistent symptoms with moderate uric acid levels, impaired renal function, prophylaxis for tumor lysis symptoms. What are the indications? Tophaceous gout, uric acid more than 9 always, persistent symptoms, renal function is compromised, and then prophylaxis for tumor lysis syndrome. Considers NSAIDs to avoid exacerbations. Now, allopurinol. Indications for uricosuric therapy, uricose lowering therapy, that is ULT, recurrent attacks, tophi, bone and joint damage, renal disease and nephrolithiasis, and then increased serum uric acid levels. Mild disease, allopurinol is the drug of choice. Moderate to severe, how much I give? 100 to 300 milligrams orally in divided dose. Allopurinol 400 to 600 milligrams, up to a maximum of 800. The problem with the allopurinol is it is a non-selective xanthine oxidase inhibitor, because the xanthine oxidase is required in various levels. Xanthine oxidase enzyme, for example, your diryphylline or whatever is the theophylline, they are xanthine oxidase inhibitors by themselves. But they inhibit the xanthine oxidase in the bronchial, this one, not at the purine metabolism. So this one is a non-selective xanthine oxidase inhibitor. What is febuxostat? It is a selective xanthine oxidase inhibitor. That is why febuxostat is a newer drug. Recent selective xanthine oxidase inhibitor, Uloric or Gyloric, it is available. Even in native Febustat, so many brands are there. 40 milligram tablets are available. You give 1 to 2 tablets as a single dose. You don't have to give one morning, one afternoon, night, not like that. Only one dose, preferably at bedtime. Give 40 to 80 milligrams, one tablet or 2 tablets. Those intolerant to allopurinol, you can use. Renal insufficiency, febuxostat can be used. Serum uric acid targets are not achieved by allopurinol, you can use febuxostat. High baseline uric acid levels, you can start. Severe tophaceous gout also, you can start. What are the newer drugs for gout? Febuxostat, of course, is one newer drug. And then benchbromorone, I already told you. Pegloticase is another drug. Losartan, an antihypertensive drug, is known to have, you have positive effect on this. Likewise, fenofibrate, an anti-lipid drug, is also used. Suppose a patient is having dyslipidemia and hyperuricemia, fenofibrate. Hypertension, hyperuricemia, losartan can be added with advantage. And vitamin C supplementation can help. Pegloticase, intolerant to allopurinol or febuxostat, and target uric acid not reach, high baseline serum urate, severe tophaceous gout, you can use pegloticase. What are the other drugs? Losartan and fenofibrate. Hypertension or hyperlipidemia, they are coexistent, you can use. Mild effect, therapy for borderline hyperuricemia, adjuvant therapy while on allopurinol. Vitamin C supplementation can be used. What way hyperuricemia can be dangerous? One, hyperuricemia is linked to obesity, hyperlipidemia, metabolic syndrome, hypertension, diabetes, renal disease, and heart failure. So, hyperuricemia is not to be brushed under the carpet. If you find uric acid more than 6 milligrams, you have to think of hyperuricemia because it is associated with all these conditions. It is a cardiovascular risk marker. Now, this is BSR. What is BSR? British Society for Rheumatology. BSR is British Society for Rheumatology. There are 10 commandments on hyperuricemia. They have published. What are these 10 commandments? Fast-acting drugs are the choice for acute gout. Should always remember, acute gout, don't think of febuxostat, allopurinol, or anything. NSAID, steroid, and colchicine are the treatment. Anti-inflammatory drugs are the treatment, should be continued minimum of 2 weeks. After that, you withdraw. Colchicine an effective alternative to NSAID, but a little slower to work. Intra-articular steroids are highly effective if it is monoarticular gout. Oral or parenteral corticosteroids for NSAID, contraindication. Allopurinol should not be used for acute gout. Again and again, we are telling the same thing because you will be using. The moment you see a hyperuricemia, your choice is febuxostat. And if you see a gout patient with acute attack, that should not be your choice. So to drive that point, we are telling allopurinol should be continued if the patient is already on allopurinol. Suppose some fellow is on allopurinol, continuing, he has got acute attack. No, your acute attack, stop your allopurinol. No, continue the allopurinol and add an okay. Diuretic use, if it is there, you change to other diuretic, loop diuretic, and then thiazide diuretic you avoid. Uricogenic treatment must be started after the second attack. Newer drugs in refractory cases with high serum uric acid level. Hippocrates described gout as the king of the diseases and the disease of the king. He wrote around 400, 500 years ago. It is a disease of it is the king of the diseases and the disease of the king. Because such an acute disease, such a painful disease, the king of the disease of the king, because they are having effluent, lot of meat, alcohol, everything they will have. So naturally, the disease of the king and king of the diseases. Okay. So you have class. What got the stage is you should know. Acute, tophaceous, or chronic, or is it gout at all? First of all, is it hyperuricemia gout? Yes, it is because the uric acid level is 8.3. And he has got, she is a female patient, sudden onset of acute right toe pain and knee joint pain. It's okay. He had history of 3 previous attacks. Heart is there. And then past medical history, hypertension. Thiazides are there. He has used thiazides for the hypertension. And his physical examination unremarkable. Swollen and tender right grade 2. And then WBC are increased. And uric crystals are present. What else is required? It's a demonstrated case of acute attack. Now, what you should not do, among those, what is your option? There are 4. Discuss risk factors for gout to include obesity, but continuous weight loss and switching to hypertension medication. That should be done, isn't it? Then start colchicine at 0.6 milligrams BID, and then start uric treatment after 4 weeks. It's also okay. Start treatment for acute pain with NSAIDs, but without a uric treatment. That's also true, because we can start either colchicine or NSAIDs or intra-articular. Intra-articular avoided here because she has got knee joint as well as the podagram. So more than one joint, intra-articular out. You can give oral steroid. Now the first one you see, starting allopurinol, 300 milligrams every day with an NSAID for acute. There is no role for allopurinol in acute. So the answer is, what sort of the gout is this? Chronic tophaceous gout. This man has got tophi. He has a frequent use of NSAIDs. His captopril can continue because that's got S inhibitors and ARBs have a favorable effect. That can be continued. BMI is high. BMI should be brought down. Uric acid lab is 7.5 milligrams. ESR and WBC normal. ESR slightly elevated. There is already radiological change. It's a chronic tophaceous gout. What is the best treatment for this patient? She is having pain also. Okay, NSAIDs are not controlling the pain. Then what do you do for pain? Colchicine is the drug when you don't get relief with the NSAID. Since it is a chronic gout, I am justified in putting anti-synthesis drugs also. Like, I'll call you later. Okay? I'll call you later. So, here, when a patient with chronic disease and also acute attack comes, you treat the acute and also treat the chronic part by adding a combination of allopurinol and colchicine. In the previous case, there is no chronicity, it's an acute attack. There is no role for allopurinol in that. In this case, start colchicine. How much colchicine we give? Normally, if 0.5, it is available as 0.5 mg tablets. 0.5 mg up to a maximum of 6. Every 2 hours I have to give. Not BID. Start colchicine every 2 hours. BID is wrong. Every 2 hours you have to give, and urate lowering drug also. Advise patient to discontinue NIH therapy and use low-dose prednisolone daily for prophylaxis. That's also possible. You can also give this one, colchicine and uric drugs with probenecid, and and then since patient is in between attack, just start urate. No, he is not in between attack. He is having the best option would be A. So, what will be the best option? To start the uric and allopurinol along with the colchicine. Or the other option is you can use prednisolone for this one and also have allopurinol. Pure prednisolone alone is no use. That's why B is not an option. C is colchicine and uric treatment with probenecid. There is no role for the uric treatment here. Probenecid is a uric drug. Either you give acute treatment and then the xanthine oxidase inhibitor, not a uric drug. Sulfenpyrazone and probenecid are uric drug. Okay? So this is the second case. Now how about the third? So what type of patient is this? First of all, you must know this this man is taking already allopurinol, xanthine oxidase inhibitor. And over the last 20 years, there is gout history with NSAIDs for acute flares. He is taking whenever acute flare is there, NSAIDs they are giving. However, the acute attacks have become more common. He was placed on chronic NSAID therapy. Now, hypertension is there, chronic renal insufficiency is there. How can you give NSAIDs for long term. There is a question mark on that. No acute symptoms now. Synovial changes are already seen. Tophi are there. This is a chronic gout with frequent acute attack. At the moment, not in acute. The best treatment option for this patient would be replace the NSAIDs with prednisolone. Do not change allopurinol dose. Doing much worse because NSAID is better than prednisolone. Already hypertensive fellow, already is having, the BMI 34. You still want to put him on steroid also, not option, isn't it? Then continue to increase the allopurinol despite his renal issue. Allopurinol can be increased up to a maximum of uric acid level until it comes to 6 milligrams per deciliter and replace the NSAID. And then continue NSAID therapy for prophylaxis. No, counsel patient long-term NSAID use and hypertension can contribute to increased renal disease. That counseling is important, but continuing will lead to problem. Discontinue all current medicines. Replace them with colchicine. Why? Colchicine is for acute attack. This fellow is not an acute attack. Why should I give colchicine? None of the above. So the best option appears to be increase the allopurinol dose until the uric acid comes to 6 milligrams and try to replace the NSAIDs with Tylenol or some other indomethacin or milder analgesic type of drugs. That will be the, what is he? He is an elderly person, 62-year-old fellow, pain swelling of the left grade to MTP joint, very much suggestive of gout. Examinations are judgment as warm, swollen, tender touch. So we have got a clinical evidence there. No history of previous attack. Patient has a history of diabetes mellitus controlled by diet and has hypertension. His medications are thiazide diuretic and a CBC and blood chemistry profile are normal except that the uric acid is elevated. What is this fellow? This fellow is a drug-induced gout. If you stop that particular drug, see, he has no previous attack, he only has an acute attack, and his treatment for hypertension, there are several drugs, are not hydrochlorothiazide alone. Hydrochlorothiazide is taking for years. Now blood chemistry, everything is normal. No uric acid crystals were demonstrated, except for the joint acute attack. And then the uric acid levels are 9.2. No point in putting allopurinol because it's not a chronic case. No point in trying NSAID, is already hypertensive. Best thing is there's an offending drug is there, like pyrazinamide, this hydrochlorothiazide, loop diuretics. We know these are the drugs which can cause. Stop the drug and see what happens. The uric acid, just like the other lady who had pyrazinamide-induced hyperuricemia. I did not do anything. Just counseled her and then removed, I allowed her to continue the drug with a little support of NSAID because I can't stop the anti-ATT before 2 months. It will lead to drug resistance. And she is a young woman. So there's no other joint involved. Little NSAID support, more water intake, and then allowed her to pass the 2 months phase. She developed around 1 month. 1 more month she continued, then she dropped the drug, she has become on. In this case, thiazide can be replaced. This attack should resolve spontaneously in 2 days. That means, you allow the fellow to suffer. Allopurinol should be started. No. Elevated uric acid, no. Elevated uric acid alone is not sufficient. You must have so many other things. Intra-articular injection should be avoided. In fact, if possible, you can give also, nothing wrong. It need not be avoided because it kills the pain immediately. Stopping hydrochlorothiazide may control hyperuricemia. Now, it's a male patient of 32 years, 12-hour duration of MTP joint involvement. Joint is very tender to touch and denies any history of trauma. Because I have sudden joint pain on the MTP joint means I have to hit against the wall. So first that has to be excluded rightly. Suddenly something you can hit against a stone or a wall and then get a pain there. Okay, he is on no medication, 32-year-old fellow. Exam is normal. Large area of erythema over left leg and toe, left large toe, the great toe, up to onto the dorsum of the foot. There's not a filaral lymphangitis or any cellulitis. That also ruled out. Because any erythema, swelling of the foot can be lymphangitis or cellulitis. That is ruled. Now, he is having an acute diagnosis, acute pain suggestive of acute attack. How do I confirm the diagnosis? That's what there are. So, which of the following tests will help you for a definitive diagnosis? Gram stain of the fluid aspirated from the joint, 24-hour urine protein, and X-ray of the foot and ankle, microscopic examination for crystals in the synovial fluid, intravenous pyelogram. Why intravenous pyelography for this fellow? Not at all required. Ruled out. Okay, 24-hour urine collection for uric acid, if you do, that's a different story. That's for treatment plan. That's for chronic gout, not an acute gout. So that also is ruled out. X-ray the foot and ankle, one attack, 32-year-old fellow, what X-ray this will be there? Taking an X-ray is useless, isn't it? So, gram stain of the fluid to be aspirated, septic arthritis should be ruled out. And you should know that there are crystals there and demonstrate it is acute attack of flow. So, you require aspirate the fluid, put for gram stain, look for Polaroid microscope, light birefringence. Okay, negative birefringence. Okay, synovial aspirate will be the best. Once you have aspirated the synovial fluid, you can even do the gram stain also. Okay, so those two will be the answer. So this is how you work up the case. Now let us look at the same fellow. The discussion is all same only. Yeah. Same fellow say 5B we are continuing. So nothing new. Now we are asking what treatment you wanted. Earlier what diagnosis you do. Now what treatment you wanted to. Acute attack, what is the treatment? Yes, sir, it is. Certainly allopurinol not. We don't want to give. Indomethacin can be considered. Prednisolone possible. Probenecid not required. Uricosuric drug. Colchicine, if NSAIDs and steroids fail, then colchicine will come. Isn't it? So, the three options are possible. Indomethacin, colchicine and prednisolone. Order should be indomethacin. If not contraindicated, give it. If contraindicated or no response, consider steroids. Steroids are contraindicated, consider colchicine. That is the order. That's what I have showed you. So, the indomethacin is the first choice. Then you can consider this prednisolone and finally consider colchicine. Probenecid and allopurinol should not be considered. You understood the message? How you are treating a fellow. Some case histories also will motivate you to know how to learn. Whatever you have learned. These cases are not mine. These are the British Society of, I showed you know, the British Association for Rheumatology. And now, finally, there is one more thing about the same fellow. They are asking. So, treatment would be colchicine, prednisolone, and indomethacin. Okay. Now, there is some more little history they are given. You are able to aspirate from the joint. The diagnosis to establish the gout. Which of the following joint findings will establish the gout? Negatively birefringent needle-shaped crystals under Polaroid microscope. Positively birefringent, no. Snowball-like aggregates, no. Dumbbell-shaped octahedron crystals, no. Only thing is negatively birefringent. I have shown you how it looks. And avoid spinach.